Hi, my name's Sam Klempner. I'm a GI medical oncologist at Mass General Hospital in Boston. I'm here to take you on a really quick walk through the upper GI tract, highlighting some key abstracts from ASCO 2021. So we'll start in the esophagus with Checkmate-648. This was really asking the question of whether or not we can improve upon standard of care chemotherapy in previously untreated advanced esophageal squamous cell carcinoma. It was a phase 3 trial designed to examine two arms, a chemo-free ipilimumab plus nivolumab and a chemotherapy plus nivolumab, both of which were compared against standard chemotherapy. What we saw is that both arms demonstrated activity. There was an improvement in overall survival in the nivolumab plus chemotherapy versus chemotherapy, and an improvement in overall survival in the nivolumab plus ipilimumab versus chemotherapy. Taken together, I think this data in combination with Keynote-811 really lends strong support to the idea that in newly diagnosed advanced squamous cell carcinoma of the esophagus, chemotherapy plus PD-1 represents a standard of care. Ipilimumab plus nivolumab may be an alternate option, and we await regulatory input on whether or not this will be an approved option for the frontline setting. Moving a little bit farther down the esophagus, although containing squames and adenos, we saw some updates from the very seminal Chechmate-577 trial. So this was asking the question of whether or not adjuvant immunotherapy improves outcomes in patients after trimodality therapy. So patients were put down a curative intent pathway, chemotherapy and radiation, followed by surgery, and then anyone with less than a pathological complete response was randomized to nivolumab or nothing. What we saw is that adjuvant nivolumab for 1 year improved disease-free survival from 11 to 22 months, which is a substantial improvement in this population. And this led to a regulatory approval recently for adjuvant nivolumab after trimodality therapy. This is really important to remember that about 80% of our patients will not achieve a pathologic complete response, particularly adenocarcinomas. So this applies to a large majority of patients who we see in the clinic. Moving just a little bit farther down the GI tract into the GE junction and stomach, we saw the first interim analysis from Keynote-811. This is asking the question of whether or not adding immunotherapy on top of standard chemotherapy and trastuzumab improves outcome in HER2-positive patients. There was some very encouraging phase 2 data, and this first interim analysis of Keynote-811 suggests a very high activity for this regimen. So the overall response rate was 74% in the experimental arm containing pembrolizumab and 52% in chemotherapy plus trastuzumab. The waterfall plots are quite impressive, with a lot of patients achieving very deep responses, and we await progression-free survival and overall survival, but this very encouraging early activity led to the regulatory approval in May of 2021 for this regimen. Moving a little bit farther down the GI tract into the hepatobiliary system, we saw some really interesting data in hepatocellular carcinoma. The FOHAIC trial was a phase 3 randomized trial comparing sorafenib versus hepatic intra-arterial chemotherapy with FOLFOX. This is an approach that has demonstrated activity in the past, but I believe this is the first phase 3 trial to demonstrate an improvement in overall survival versus sorafenib with this approach. Certainly, it's limited to centers with experience with this approach, and it remains to be seen if this data will hold in the modern era where atezolizumab and bevacizumab is the standard frontline HCC therapy across much of the world. However, this was a very clean data set and demonstrated clear activity and substantial intrahepatic response rates for this hepatic intra-arterial infusional approach. Finally, we'll end with one of the better named trials of all of ASCO 2021, the phase 2 NIFTY trial. This was investigators attempting to build upon data in the second-line therapy for biliary tract cancers. As we know, after gemcitabine and cisplatin, we have FOLFOX data from ABC06, and these investigators wanted to examine whether or not NALIRI, nanoliposomal irinotecan with 5-FU, was superior to 5-FU alone in people who had failed gemcitabine and cisplatin. The take-home message is that the nanoliposomal irinotecan and 5-FU was superior to 5-FU alone. This remains to be seen whether this will be carried forward, but I do think the data can be interpreted that after gemcitabine and cisplatin, we have evidence supporting both FOLFOX from the ABC06 trial, and this data set supporting 5-FU and nanoliposomal irinotecan as second-line considerations for this difficult-to-treat population. Thank you very much, and I hope you enjoyed this brief update.